I'm Curtis Smith. You probably remember me from yesterday. Hopefully your memory is not that shot after being in this room for many, many hours. So as I mentioned yesterday and today as well, I have no conflicts of interest related to this presentation. The objectives are three main objectives. The first one is to identify presenting signs and symptoms, etiology, risk factors for various infectious diseases. We're going to go through these really quickly, but respiratory tract infections, urinary tract infections, skin and soft tissue infections, osteomyelitis, CNS infections, intra-abdominal, C. diff, and finally endocarditis. We're also going to talk about appropriate treatment then for those same disease states, infectious diseases. And then finally, we're going to talk about appropriate preventive therapy for respiratory tract infections, CNS infections, endocarditis, and surgical wound infections. So here's the agenda, the disease states that I just went over. There are pretty much cases in most of these areas, not all of the areas, but most of these will have cases related to that particular area, and then we'll talk about the information and the most appropriate therapy. And again, at the bottom of the slides, the same thing as yesterday, there's going to be a page number in the workbook, if you do have the workbook in front of you. And then also an answer page. If there is a particular case, it'll tell you the page number that answers that particular question. So we're going to start with patient case 1. So this is RL. And RL is a 68-year-old male who comes to the emergency department, chief complaint of cough and shortness of breath. His symptoms began about 4 days ago and have worsened over the last 24 hours. He's now coughing up yellowish-green sputum, complaining of chills, and he has a fever as high as 102.4 at home. His past medical history includes coronary artery disease with an MI 5 years ago, CHF, hypertension, and osteoarthritis. He rarely drinks alcohol, and he quit smoking when he had his MI. Meds on admission include lisinopril, hydrochlorothiazide, and acetaminophen. He is alert and oriented, so he's not confused. His vital signs include an elevated temperature, an elevated heart rate, respiratory rate, and slightly elevated blood pressure. His labs are normal except for an elevated BUN. Serum creatinine is 1.23, slightly elevated as well. And on chest x-ray, the cornerstone for pneumonia, he has infiltrates in the right lower lobe. At this time, we don't have a sputum sample because he's just presenting, so we don't have any results from a sputum sample. So a little bit about community-acquired pneumonia, and if you have the handout in front of you, you'll have to flip back a few pages from the case. But his symptoms are very typical of community-acquired pneumonia. So he has the cough with productive sputum, shortness of breath, chills, fever, and again, that positive infiltrate on chest x-ray, which is really the key there for his pneumonia. Now, it is recommended that anybody with pneumonia, community-acquired pneumonia, that you use some sort of scoring system. The scoring system helps you decide primarily whether you're going to treat the patient at home or whether you're going to treat them in the hospital. So there's a couple of scoring systems. The PORT scoring system is a very good scoring system, but it's very complicated. The easiest and something that you can do off the top of your head is CURB 65. And the information on CURB 65, again, is in your handout. There's 5 things there, whether they're confused, uremic, whether they have elevated respiratory rate, whether they have any sort of blood pressure changes, and then finally, whether they are 65 years of age or over. And then based on that, you get a point for each of those, and based on your CURB 65 score, that'll tell you what your overall mortality risk is, and then that will help you decide whether the patient needs to be hospitalized or whether they can be treated at home. So in this patient, his CURB 65 score is 2 based on his age and his uremia, so his elevated BUN. He's not confused. And if you look at in your handout, then his blood pressure is not low. It's actually elevated, so he doesn't get a point there. And he does get a point actually for his respiratory rate, which was 32. So really, in this particular case, it should be a CURB 65 score of 3. Either way, a score of 2 or 3 would lead you to hospitalize and treat the patient in the hospital rather than at home. And the most common organisms are listed there: strep pneumo, mycoplasma, and Haemophilus influenza. So considering that you're going to treat this community-acquired pneumonia patient in the hospital, what is the best empiric therapy? Ampicillin-sulbactam, piperacillin-tazobactam with an aminoglycoside, gentamicin, ceftriaxone plus azithromycin, or doxycycline. Thoughts? All right, seeing good color there. So we'll talk about some things and then we'll go back and review the answer to that question. When you are addressing a patient with community-acquired pneumonia, the first thing you have to decide is, am I going to treat this patient in the hospital or will I treat them as an outpatient? And then once you've decided that, you have another decision tree for each of those. So in the first one, if you are going to send the patient home, treat them as an outpatient, then you have to decide, then your antibiotics are based on whether they are healthy or whether they have comorbidities and whether they've had antibiotics in the past 3 months. So if the patient is healthy and has not had antibiotics in the past 3 months, this is the simplest patient, treated as an outpatient, then you treat them with either a macrolide alone or doxycycline alone. If they do have comorbidities or they've had antibiotics in the past 3 months, then you treat them with a respiratory fluoroquinolone, and you notice there ciprofloxacin is not one of those listed. So a respiratory fluoroquinolone or a macrolide with either high-dose amoxicillin, high-dose amoxicillin clavulanate, or a cephalosporin, and there's some cephalosporins that the guidelines list. So this is community-acquired pneumonia as an outpatient, not as an inpatient. If you're going to treat them as an inpatient, then you have to decide whether this is a moderately severe case or more of a severe case. And the way you basically decide that is whether you're going to send the patient to a regular floor in your hospital or whether you think they need to go to the ICU. So if it's someone that you feel just needs to go to a regular floor and they can be admitted to that floor, then the recommendations are a fluoroquinolone or a macrolide plus a beta-lactam. And the vast majority of the time, that's a macrolide plus a third-generation cephalosporin. But you could use ampicillin, you could use ertapenem as well. And then those that you send to the ICU, you need to use combination therapy, which would be ampicillin-sulbactam plus either a respiratory fluoroquinolone or azithromycin, or another beta-lactam like a third-generation cephalosporin plus a respiratory fluoroquinolone or a macrolide, specifically azithromycin. So combination therapy if you're sending to the ICU, and then if they're sick enough to go to the ICU, then really that's a risk factor for MRSA, and you should at least begin empirically treating them for MRSA until you get culture results back and can narrow as necessary. So in this particular patient in RL, remember because of his CURB 65 score, we're going to admit him into the hospital. Probably doesn't need to go to the ICU, so we're going to send him to a regular floor. And so of all these options, then the correct answer is C, ceftriaxone plus azithromycin. A is incorrect because it doesn't have the macrolide there. B is overkill. You're treating more of pseudomonal infection, and in this case, this CAP case, Pseudomonas is probably not going to be a player at all. And D, doxycycline, that would be the simplest therapy for an outpatient CAP in a patient who is healthy and has not had antibiotics in the last 90 days. All right, we're going to move on now to another pneumonia case. This is BP. BP is a 66-year-old female. BP is admitted to the hospital and undergoes a 2-vessel cabbage, and that was 8 days ago. Since the cabbage, she's been on a ventilator in the surgical intensive care unit. She's now on the ventilator, and she is now spiking temps, and she has a tracheal aspirate that's showing many white cells and gram-negative rods. Her past medical history is coronary artery disease with an MI 2 years ago, COPD, and hypertension. And like I mentioned, she's been in the hospital, in the ICU for 8 days on a ventilator. So the question is, at this point, in this patient who has pneumonia, or we believe has pneumonia, what is the best empiric therapy for BP? Ceftriaxone plus gentamicin plus linezolid, piperacillin alone, levofloxacin plus linezolid, or cefepime plus tobramycin plus vancomycin? Something to think through a little more. Good. Getting good responses for those that are still in the game. Thank you for putting the cards up. That's helpful for me. So this is a nosocomial pneumonia, and there's 3 types of nosocomial pneumonia. Hospital-acquired pneumonia, those are patients who have pneumonia after 2 days of being in the hospital. So in the first 2 days in the hospital, it's still considered community-acquired. You probably came in with it. After 2 days, hospital-acquired. Ventilator-associated pneumonia, which is, again, pneumonia in a patient who is ventilated. And finally, healthcare-associated pneumonia. And these patients, even if they are their first minute or their first a few minutes in the hospital and you notice that they have pneumonia, they are at risk of multi-drug-resistant organisms and need to be treated accordingly. So HCAP, or healthcare-associated pneumonia, people who have been hospitalized in the past 90 days, people who reside in long-term care facilities, people who've had IV antibiotics or chemotherapy within the past 30 days, those that attend hemodialysis or other clinics within a hospital. The hemodialysis clinic doesn't have to be in a hospital. That can be anywhere. And then finally, home wound care within the past 30 days. So those are risk factors for HCAP patients. So whenever you have a pneumonia patient coming into the hospital, you need to assess them for these risk factors because it changes our therapy. We then need to treat them for multi-drug-resistant organisms. Now, these are the risk factors in BP. BP's on a mechanical ventilation. She's had that recent cabbage, which puts her at risk. She's had a prolonged hospitalization and ICU stay. She's older, and she has underlying chronic lung disease. And in patients who have hospital-acquired pneumonia, the organisms that predominate are gram-negative organisms and Staph aureus. And those who are at risk of multi-drug-resistant organisms predominantly is Pseudomonas and MRSA. Those are the 2 most common organisms you're going to see in those at risk for multi-drug-resistant organisms. So here are the risk factors for multi-drug-resistant organisms. These are people where you really need to target anti-Pseudomonal activity and anti-MRSA activity. Those risk factors include having antibiotics within the past 90 days, being hospitalized for 5 or more days, and remember in our patient, she's been in the hospital for 8 days, having a high resistance in the community or hospital unit, which some people might argue is everywhere, at least in the U.S. or in North America. And then those risk factors for HCAP, that puts you at risk for multi-drug-resistant organisms. And finally, family members with MDRs and immunosuppressive disease and or therapy. So our patient is at risk for those multi-drug-resistant organisms. Now, within nosocomial pneumonia, there are 2 types. There's early onset and there's late onset nosocomial pneumonia. Remember, the first 2 days is community-acquired pneumonia because you're believed to have come into the hospital with the pneumonia. So then after those first 2 days, we call it early onset hospital-acquired pneumonia. Those are people that are greater than 2 days but less than 5 days, which is considered late onset hospital-acquired pneumonia. So basically, it's people who've been hospitalized for 3 or 4 days, day 3 of hospitalization or day 4 of hospitalization. It's a very small group of individuals, and so therefore, you won't be in this situation that often. Occasionally, I see patients that fall into this particular category, but it's not as common as the late onset. So in these patients, you're not as worried about the multi-drug-resistant organisms unless they have those other risk factors, the HCAP, family members, et cetera, that I just went over. You're not as concerned about multi-drug-resistant organisms, and therefore you don't have to treat for Pseudomonas and MRSA, and you can get away with one of the drugs in one of these 4 categories. Either a 3rd-generation cephalosporin, usually ceftriaxone, a fluoroquinolone, and you can see here Cipro can be used in this instance, ampicillin sulbactam, or ertapenem, one of those 4 agents. Now, what is much more common is late onset pneumonia. These are people who have been in the hospital for 5 or more days, or anyone who has risk factors for multi-drug-resistant organisms. People with HCAP, people with family members, people who have been on antibiotics in the past 90 days, et cetera, that list that I just went over. So in those patients, you need to give an anti-Pseudomonal beta-lactam, And I've listed a bunch of them there, either one of the anti-pseudomonal cephalosporins, ceftazidime or cefepime. And by the way, if you're not familiar with the newest cephalosporin combinations before the exam, you should look up those a little bit. So ceftazidime and avibactam combination, or ceftolozane and tazobactam, new combination beta-lactamase inhibitors with cephalosporins, both anti-pseudomonals. You could use one of the anti-pseudomonal carbapenems, so imipenem, meropenem, doripenem, or piperacillin, tazobactam, the anti-pseudomonal penicillin. Plus, the guidelines do recommend an aminoglycoside or a fluoroquinolone, so 2 agents for Pseudomonas. And maybe in your institution you don't use 2 agents. That's a little bit of a controversial area. There's a good section in the guidelines that talk about why they recommend 2 agents. So if you want to go back and look at that, that will give you a lot of information in that regard. The guidelines are pretty old. They were published in 2005. They've been in the update process probably for the past 4 years, and every 6 months they just kick it up and say it's coming out whenever. So it's currently supposed to come out in spring of 2016. And so we're here right now, but soon I think that's going to be kicked up to fall of 2016, as it has been for the past 4 years. Eventually they have to come out, but they haven't been updated in 11 years, and so there are updates that need to be made. The CAP guidelines are old as well. They haven't been updated in about 9 years or so. And again, they are going through that same process where they're being updated, and they keep getting kicked back 6 months. There have been a number of review articles that have come out for both of these areas, though, CAP or nosocomial pneumonia, and they haven't really made any drastic changes in what is currently recommended in the guidelines. So I don't know how much the guidelines will actually update what is currently recommended. All right, so 2 agents there for Pseudomonas, and then because MRSA is a risk, you need to add an MRSA active agent, either vancomycin or linezolid is generally recommended. And I've listed there on the slide, and it's in your handout, who are those patients who are at risk for MRSA. But basically anyone who's at risk for multi-drug-resistant organisms needs to be on an anti-MRSA agent at least until culture results come back and you can narrow. So what is the best therapy for BP? Well, BP has been in the hospital for 8 days. Therefore, that puts her at risk for multi-drug-resistant organisms, and therefore you need to treat empirically for Pseudomonas, ideally with 2 anti-Pseudomonal agents plus an anti-MRSA agent. So basically that means the correct answer is D. A is incorrect because ceftriaxone does not have anti-pseudomonal activity, and then B is incorrect because there's no anti-MRSA activity, and at least the guidelines would recommend adding a second anti-pseudomonal agent. And the same thing for C, the guidelines recommend adding a second anti-pseudomonal agent. All right, finally, about vaccinations, and I know that one of the speakers went over vaccinations yesterday, so I'm going to quickly go through this. So what vaccinations would you recommend for BP now? Remember her age, and she hasn't had any vaccinations, and she has other risk factors, I think, too, heart disease, et cetera, that would require vaccination. So what vaccinations? She doesn't need any, which I sort of just told you that's incorrect right now. She should receive pneumococcal now and influenza vaccine in the fall. She should receive influenza in the fall, but due to her current infection, she doesn't need pneumococcal vaccine. And finally, she should receive pneumococcal now, but influenza vaccine is not needed. And the correct answer is B. Before I get to that, I'm going to talk a little bit about influenza, sorry. There's information in your handout related to influenza that goes over how do you differentiate influenza from a cold, a little bit about the pathophysiology, and information on the treatment, including drugs to treat or prevent, primarily oseltamivir, but zanamivir, and then the newest IV agent, peramivir, are also options for treating and for some of those preventing influenza. Vaccination-wise, very quickly, because you got this yesterday, there's 2 pneumococcal vaccines. The Prevnar or PCV13 is what's recommended first, and then a year later, in most patients, pneumococcal or PPSV, the polysaccharide vaccine 23, after that. So in this patient, she does need pneumococcal vaccines because of her age. She needs both of them, so she should get PCV13 first, and then a year later, PPSV 23. And then influenza vaccine, basically everyone needs influenza vaccine. And I've listed those influenza vaccines there. So going back to that, the recommendation then, or the correct answer for case number 3 is BP should receive pneumococcal now and influenza in the fall. And she should receive PCV13 now and then PPSV 23 a year from that PCV13 vaccine. The sinusitis guidelines were published about a couple of years ago, and so I have information in your handout related to sinusitis. I don't have any cases on sinusitis, but I would recommend that you go through and you look at how to differentiate viral sinusitis from bacterial sinusitis. That's one of the big things that the first things you have to do is figure out whether this is bacterial or viral. And then if it is bacterial, the recommended therapy is amoxicillin clavulanate, first line, either regular or high dose. And then second line agents include quinolones, doxycycline, or cephalosporins with clindamycin. And then the duration is either 5 to 7 days for adults or a longer period of time in children. Patient case number 4 then is related to urinary tract infections. So this is GN. GN is a 62-year-old woman, and she presents to the clinic with a 3-day history of urinary frequency and dysuria. Over the last 24 hours, she's had nausea, vomiting, and flank pain. She has type 2 diabetes, hypertension, and a history of multiple DVTs, and she's currently receiving glyburide, enalapril, warfarin, and metoclopramide. She's alert and oriented, elevated temperature, 102.8, a heart rate of 120, respiratory rate of 16, and she has some orthostasis going on as well. Her labs are normal except her INR is 2.7, but remember she's on warfarin, and her creatinine is somewhat elevated and her white count is at the upper end of normal. On UA, she has turbid urine. She's also spilling glucose into her urine, which is more of a sign of her diabetes rather than the urinary tract infection, but the protein as well. But she also has white cells in her urine, positive for nitrites, and positive for bacteria and casts, all indicating that she has a urinary tract infection. So how should GN be treated? Trimethoprim sulfa, BID for 7 days. Ciprofloxacin, IV BID, and then switch to oral and treat for 10 days. Gentamicin for 3 days, once daily dosing, it's not high-dose extended interval. It's standard traditional dosing, but because of her renal function, we'll only give it once a day for 3 days. Or tigecycline IV followed by doxycycline for 10 days. Now, one thing, again, when you are taking the exam, someone mentioned it yesterday as well, it's going to look for the best answer. And in ID, this can be very frustrating because you'll look at those and say, I wouldn't do any of them. But you have to pick of the options which is the best option and go with that. So keep that in mind. So let's talk about UTIs. So these are the organisms that are most involved in UTIs. You can see that in an outpatient or a community-acquired UTI, E. coli is by far the predominant organism. 3/4 of the cases are due to E. coli. And then other organisms, including Staph, Saprophyticus, Proteus mirabilis, and Klebpneumo, Enterococcus as well, can be involved. With nosocomial UTIs, a little different. You can still see that E. coli predominates of all the organisms, but now you see other gram-negatives, including Pseudomonas there, Klebsiella, Staph can still be an issue, and fungi are also involved in nosocomial UTIs. Now, what are the predisposing factors in GN? So when you're addressing a patient with a UTI, you need to, again, sort of like in pneumonia, figure out what kind of a UTI it is, because that's going to direct you into the most appropriate therapy. So similar to as we talked about in community-acquired pneumonia, there's two different decision trees that you have to go through. The first is whether it's complicated or uncomplicated, and I have a list of those factors that will help you decide whether it's complicated or not. GN has a few of those factors, specifically diabetes mellitus, that is a complicating factor. So we know because of her diabetes, this is a complicated UTI. And then the other decision tree you need to go through is whether this is a cystitis or whether it's pyelonephritis. And because of her symptoms of more systemic disease, including fever, sort of elevated white count, the fact that she has flank pain, those are all leading us to believe that this is a pyelonephritis. So we've gone through those two decision trees, and now we can diagnose her with a urinary tract infection, but specifically with a complicated pyelonephritis. And that's going to help us decide therapy as well as length of therapy. So here's the factors associated with complicated UTIs. Any male with a UTI is complicated, and then anybody with anatomical issues, diabetes, recent antimicrobial use, etc., would push you into the category of complicated UTIs. So, how do we treat? This is the simplest UTI. There are guidelines for this particular UTI, and that's an uncomplicated cystitis. So these would be women only, and generally younger women, but women with no other complicating factors such as pregnancy or diabetes or anatomical issues, recent antibiotics, etc. So in those patients, your options are either trimethoprim sulfa, nitrofurantoin, or fosfomycin. Quinolones and beta-lactams are not first line, they are alternatives. And depending on which antibiotic you're going to choose, that will then direct you into the length of therapy. So Bactrim you use for 3 days, nitrofurantoin for 5 days, and fosfomycin for just 1 dose. Now, if it's pyelonephritis, uncomplicated pyelonephritis, again, this would be in generally a younger female, but uncomplicated pyelonephritis, then your options are a fluoroquinolone, trimethoprim sulfa, or a beta-lactam, one of those three. And depending on which one you pick, then that also impacts your length of therapy. So the older agents, trimethoprim sulfa, beta-lactams, you treat for a longer period of time, Bactrim all the way up through 14 days, whereas fluoroquinolones have data supporting shorter durations of therapy. So levofloxacin specifically was tested at 5 days versus 10 days of Cipro and found to be just as effective. So for quinolones, you can go through a shorter length of therapy because they've been tested at shorter length of therapy. You notice that, however, on this list, that if your uropathogen resistance, specifically E. coli, is high, is greater than 10%, and look at your antibiograms, and lots of places it's greater than 10%, then they do recommend an initial dose of either a long-acting beta-lactam or an aminoglycoside. So basically an initial dose of ceftriaxone or an aminoglycoside, and then go to the therapy that you see listed there. Same thing applies for Bactrim if the sensitivities, again, are not that great. So if you have 20% resistance in E. coli to Bactrim or levofloxacin, et cetera, then you need to do that initial dose. Complicated UTIs, this is whether it's cystitis or pyelonephritis. You have to treat for a longer period of time unless it's the fluoroquinolone. Again, there's data with shorter lengths of therapy with fluoroquinolones. And your option are either a fluoroquinolone, an aminoglycoside, or an extended spectrum penicillin, or extended spectrum beta-lactam. Ceftriaxone is usually used in this situation. So one of these three agents for complicated UTIs, 10 to 14 days usually of therapy unless it's a fluoroquinolone, and then you can go shorter. And then finally, in pregnancy, the recommended length of therapy is 7 days and using either amoxicillin, nitrofurantoin, or cephalexin. So how should GN be treated for this complicated pyelonephritis? Hopefully you see the answer is B. Ciprofloxacin for 10 days of therapy. So fluoroquinolone is one of those options, along with aminoglycoside or extended spectrum beta-lactam. And treating for 10 days would be an appropriate length of therapy. The aminoglycoside gentamicin could be used, but too short a therapy. Bactrim is also could be used, but A, it's going to interact significantly with her warfarin, and quinolones can interact with warfarin as well, but Bactrim is definitely going to interact significantly. So that's going to be an issue, and then too short a therapy, and then finally the last one you wouldn't use at all. Okay, also have in your handout catheter-related UTIs, prostatitis, and epididymitis. So you might want to just review therapy, especially therapy for prostatitis and epididymitis, which is longer. It's similar. The drugs are similar as you would see in UTIs, but the treatment is for a longer period of time. All right, skin and soft tissue infections or skin and skin structure infections. The main three ones are cellulitis, erysipelas, and necrotizing fasciitis. I've listed those in your handout. I don't have a case for those. And then I also have information on the shingles vaccine. What we are going to do is talk about a case in a diabetic patient. So this is again GN. And GN now returns to the clinic 6 months later after you had seen her for a urinary tract infection. And now she has an ulcer on her right foot. She stepped on something while walking barefoot, and the ulcer is red, it's swollen, it's deep, it's a deep ulcer, and maybe it could be osteomyelitis. Lab values are within normal limits, serum creatinine of 0.86. So the question is, which is the best empiric therapy for GN? Nafcillin alone, tobramycin plus levofloxacin, nafcillin for 6 to 12 weeks, tobramycin plus levo for 1 to 2 weeks, ampicillin sulbactam for 2 to 3 weeks, or a below-the-knee amputation followed by ceftriaxone. Go straight to the surgery. Okay, let's talk about diabetic foot infections. They occur because of the long-standing complications of diabetes, neuropathy, vasculopathy, immunologic defects. They're generally polymicrobial. They can be prevented by those things that I've listed there. You can divide them into mild versus moderate to severe. So in mild, where you have no MRSA risk factors and it's just more or less a cellulitis, you can treat it like a cellulitis. You don't have to do really broad therapy. But if it's more moderate to severe, it's a deeper infection, then you need to use more broad spectrum agents because you're probably dealing with anaerobes and gram-negative organisms along with gram-positive organisms. And then the treatment depends on whether it's mild, moderate to severe, or osteomyelitis. And then finally, unfortunately, surgical therapy is frequently what you end up having to go to because it's very difficult to treat these infections and clear them up due to poor blood flow and therefore lower antibiotic concentrations at the site of infection. So the correct answer for her then, this is more of a moderate to severe infection because it's deep. So we'd want to use something that is more broad spectrum. So the correct answer is C, ampicillin sulbactam, which has activity against gram-positive, gram-negative organisms and anaerobes. And the length of therapy is appropriate as well. Patient case number 6 next, osteomyelitis. So this is WA. WA is a 55-year-old male who comes in with weight loss, malaise, severe back pain and spasms that have progressed over the past 2 months. He's also starting to get some lower extremity loss of sensation. 4 months ago, he had a surgery for a fractured tibia and subsequently had an infection after that surgery. He also has hypertension and diverticulitis. He's alert and oriented, not much of a temperature, vitals look not too bad. His white count is a little elevated at 14.3. His SED rate is elevated as well as a CRP. And on MRI, it's showing bony destruction of the L1 and L2 vertebrae, and that's confirmed by a bone scan. And a CT-guided bone biopsy is now growing gram-positive cocci in clusters. So very typical things we'll talk about with osteo. So how should WA be treated? Vancomycin every 12 hours for 6 weeks, nafcillin every 6 hours for 2 weeks, levofloxacin daily for 6 weeks, or ampicillin sulbactam every 6 hours for 2 weeks. All right. Seeing some good color there. So there's 3 main types of osteomyelitis, that which comes from hematogenous spread, which is primarily in children, but adults, you see it like this patient with vertebral osteo, and there's now, as of about a year, a whole guidelines on vertebral osteomyelitis put out by the IDSA. Risk factors include bacteremia, sickle cell disease, and then they're usually microbial, usually gram-positive, usually Staph aureus, but you can see in some different risk groups like sickle cell patients, IV drug users, you can see slightly different organisms that you need to be concerned about. Contiguous spread osteomyelitis occurs due to a contiguous source of infection, and you can see the organisms listed there. And finally, sort of like a diabetic foot infection, those with vascular insufficiency, primarily adults, primarily those with diabetes or those with peripheral vascular disease. And then you see again the polymicrobial organisms, including anaerobes, gram-negatives, and the gram-positive organisms. So what do we see with WA as far as his presentation or clinical findings? Well, he had that recent surgery and infection, which probably seeded his blood, which then seeded his vertebra. He has the lower back pain and the loss of sensation beginning to occur, and then he has those nonspecific elevations in white cells, sed rate, and C-reactive protein. And then finally, what you really need for osteo is an MRI. CT scans are okay, but MRIs are better, showing bony destruction, and then that positive bone scan, which was just definitive for the osteomyelitis. So as far as antibiotics is concerned, pediatric osteo is usually gram-positive, usually Staph aureus, so cefazolin or nafcillin or clindamycin, maybe vancomycin if necessary, definitely if it's MRSA. And then in adults, again, gram-positive organism, antibiotics for gram-positive organisms, nafcillin or cefazolin or vancomycin. Sickle cell patient, prosthetic joint infection, slightly different. With osteo, you always have to treat for a long period of time. Blood flow into the bone is poor, you don't get high antibiotic concentrations, and it takes a long time to clear infection. So 4 to 6 weeks of therapy, and those with chronic osteo, even longer, and potentially up to a year of oral suppressive therapy in those with chronic osteomyelitis. So how should WA be treated? Well, again, it's osteo, so we can knock off the lower duration, so B and D are incorrect. Levofloxacin has some activity against staph, but not very good activity, and the MICs are pretty high, and it's not a good agent for bone infections. You end up sort of developing resistance over time or selecting out for resistant organisms. So the best answer is vancomycin for 6 weeks. Okay, patient case 7. Moving on in your handout. So this is on, if you're looking at the workbook, it's on page 326. And this is DM. DM is a 21-year-old college student who presents to the emergency department with the worst headache of his life. And he has a lot of pain with neck movement, so hopefully you know where this is going at this point. His past medical history is none, but he has a lot of pain on physical exam. His temperature is elevated, heart rate's elevated. His white count is really elevated, 22.5 with a shift to the left. An LP is done in this patient, and it's shown a decrease in glucose compared to his peripheral glucose. So normally CNS glucose is 2/3 peripheral. In meningitis, it's lowered, as we see in this patient. His protein is elevated, again indicative of meningitis, and then he has white cells, which generally you shouldn't see in cerebrospinal fluid, and you can see it's a predominant neutrophils. So how should DM be treated? Penicillin every 4 hours plus dexamethasone, ceftriaxone alone, ceftriaxone plus dexamethasone, or ceftriaxone plus vancomycin. All right, so seeing some there, let's talk about the etiology. So the most common organisms are either strep pneumo or Neisseria meningitidis. Occasionally you might see H. flu, but very, very rarely. So strep pneumo and Neisseria meningitidis are the big ones you want to be concerned about. Now the symptoms in DM include fever, headache, and that neck pain or pain with neck movement or nuchal rigidity. And you can see I went over the LP changes that he had that are also indicative of meningitis. With CSF, you obviously want to send it for culture, but you also want to do gram stain, and then you can do latex agglutination as well to help you really screen for the most common organisms. And then the lab findings, increased white count, which the patient had with a shift to the left, positive CSF gram stain, positive CSF cultures is almost what you see most of the time for bacterial meningitis. Treatment-wise, for kids, neonates, and infants, for kids you need to add, or for neonates you need to add ampicillin plus an aminoglycoside or ampicillin plus cefotaxime. For infants, a third-generation cephalosporin plus vancomycin, and that tends to be what we see in pediatrics then as well, and in pediatrics and adults. In older adults then, same therapy, except you need to add ampicillin. So the ampicillin is added there for listeria. The vancomycin is added in case you have a strep pneumo that's highly resistant to beta-lactams, and so you want to make sure that you have something that's active against those organisms in case that's what you're dealing with. And so that's why we start with both a third-generation cephalosporin plus vancomycin. Therapy of specific pathogens, I've listed the specific pathogens there. There's specific therapy that's listed in your handout, including duration. So duration is dependent on the organism. Neisseria meningitidis you treat for 7 days, and strep pneumo for 10 to 14 days. Adjunctive corticosteroids are a little controversial whether to use those or not. There's a lot of risks versus benefits. We do know that in kids with H. flu meningitis, there is less hearing loss. However, H. flu meningitis doesn't really happen anymore in kids because of the vaccines, or the vaccine that all children receive. There is improved outcomes in adults with strep pneumo, so it's something to consider, especially if you're concerned about strep pneumo, which most of the time you are. But the potential risk is that it could decrease antibiotic penetration, and so there's this sort of risk-benefit that you have to go through your mind, and some people would recommend using a steroid and some people not. If you're going to do that, the recommended steroid is dexamethasone. You want to give it a little bit before or at the same time as your first antibiotics, and then you use for about 2 to 4 days. And you can see that the recommendations are just in children with H. flu, which really doesn't happen anymore, or adults with pneumococcal meningitis. So the correct answer for DM then would be the last one, which is ceftriaxone plus vancomycin. So again, you have to pick what you think would be the best. You could say, well, you need to add the steroids, so I would have done C in this patient, but then you don't have vancomycin. And it's better to have the vancomycin, which is a recommended antibiotic in case there's highly pen-resistant strep pneumo, and so D becomes the better answer. All right, following the case then, or following the diagnosis in this patient, and this is case number 8, his cultures grow Neisseria meningitidis, and now there's a concern about prophylaxis. So what is the best recommendation for meningitis prophylaxis when people have been exposed to someone with meningococcal meningitis? All healthcare providers who had close contact should receive rifampin twice a day for 4 doses. Those in the dorm where he lived and classes should receive rifampin daily for 4 days. Everyone in the emergency department that night should receive a meningococcal conjugate vaccine. Or everyone in the emergency department that night should receive rifampin twice a day for 4 doses. And you laugh, but sometimes the hysteria gets to that point. All right? So Neisseria meningitis, the chemoprophylaxis that's recommended for close contacts only. So that's people who live in the same household. That could be like a roommate, not necessarily everyone in the dorm, but a roommate, or in kids, those that are in daycare. Or those that were exposed to oral secretions of the patient. So you have to be in very close contact with that particular patient. They should get the twice-a-day rifampin for 4 doses. There's also recommendations in your handout for what to do with patients who have H-flu meningitis. But again, H-flu meningitis is not very common. And then, very quickly, I'm not going to go over because it was in the vaccines yesterday. There's 2 meningococcal, there's actually a bunch of meningococcal vaccines now, but there's ones, the meningococcal conjugate that lacks the serogroup B, and then the vaccine that has the serogroup B. And there's certain patient groups that should receive either one of those or both of those vaccines. So, which is the correct answer? Well, again, any healthcare provider who had close contact should receive the 4 doses, rifampin twice a day for 2 days, total of 4 doses. Moving on to case 9. This is TS. TS is a 48-year-old male. The chief complaint, who comes in with a chief complaint of fever, chills, nausea, vomiting, anorexia, lymphangitis, and his right hand and lower back pain. He has a history only of kidney stones. He's homeless. He's an IV drug user of heroin for the past year, but he's quit 2 weeks ago. And so he's on the right path. He's alert and oriented. He has a temperature there, which you see, elevated heart rate. And a big thing is he has a systolic ejection murmur. So keep that in mind. His labs are within normal limits. He's HIV negative. A blood culture is drawn that's growing MSSA. 2 more blood cultures are drawn, and they're both now growing gram-positive cocci in clusters, probably the same organism, MSSA. And a TEE or transesophageal echo is done, showing a vegetation on the mitral valve. So hopefully you know what this is all leading to. How should TS be managed? Nafcillin alone for 2 weeks. Nafcillin plus rifampin for 6 weeks. Nafcillin plus gentamicin for 2 weeks. Or D, you need to cross this out on your slide, Nafcillin for 6 weeks. Because the endocarditis guidelines were just updated, and I forgot to take off that last statement in D. So those initial presentation, the clinical findings that TS has are the risk factors for endocarditis, his IV drug use. Endocarditis frequently it does not have abrupt symptoms. It doesn't have huge fevers, but he is showing a slightly elevated temperature, chills, and lower back pain. So that low-grade fever is somewhat indicative of endocarditis. The cardiac murmur is huge. That's very common. And then those multiple positive blood cultures over and over and over again are a huge indicator for endocarditis. The 3 most common organisms are Streptococcus, Staphylococcus aureus, and Enterococcus. And then there's some others as well, but I'm going to talk about those main 3 organisms. Viridin streptococci, the recommended therapy is either penicillin, ceftriaxone, or vancomycin. Treatment is for 2 to 4 weeks. Streptococcal endocarditis is where we use an aminoglycoside to shorten the course of therapy. So adding an aminoglycoside to the beta-lactam or to the beta-lactam can decrease your length of therapy from 4 weeks to 2 weeks, and that can be a huge issue. Now, for Staph aureus, the recommended therapy is a MSSA agent like for MSSAs, an agent like oxacillin or nafcillin. Cefazolin, or in a patient with allergies, you can use vancomycin. And then for MRSA, the recommended therapy is either vancomycin or daptomycin, but daptomycin only for native valves. Treatment is for 6 weeks, and it's no longer recommended, unless the patient has a prosthetic valve, it's no longer recommended to add an aminoglycoside in this setting, either for MSSA or MRSA. And finally, enterococcus, the recommended therapy is either penicillin G or ampicillin or vancomycin plus an aminoglycoside. And in this instance, you must use an aminoglycoside. It is not there just to shorten therapy. It's there as an important component of therapy, leading to greater efficacy. And you must include it for the entire length of therapy, 4 to 6 weeks. So strep, you add the aminoglycoside to shorten therapy. Staph, you no longer add an aminoglycoside at all. Enterococcus, you add the aminoglycoside. For efficacy, you have to add it, and it's there for the entire length of therapy. So in TS, then, who has MSSA, we need to treat for at least 4 to 6 weeks. We don't need to include an aminoglycoside. He doesn't have a prosthetic valve, so the correct answer is D, nafcillin for 6 weeks. Okay, patient case 10. This is the same patient. This is TS, 6 months after treatment for his endocarditis. So he's treated it effectively. He comes into his dentist for a tooth extraction. So which antibiotic prophylaxis is best? A, tooth extractions don't require prophylaxis. B, amoxicillin 2 grams 1 hour before the extraction. C, amoxicillin 1 hour before, and then 3 grams, and then 1.5 grams 6 hours after, every 6 hours after, for 4 doses. Or TS does not need prophylaxis because he has no risk factors for endocarditis. So there are 2 tables in your handout. There's a table that goes over or conditions in which prophylaxis is necessary, what sort of dental procedures you need to give prophylaxis for. And then there's also a table that goes over which sort of procedures, dental procedures or respiratory tract procedures that you need to include. So that's table 15 that has conditions. So what is it about the patient that puts them at risk? And then what procedures do you need to use prophylaxis for? You don't have to use prophylaxis for every dental thing that happens, and you obviously don't need to use prophylaxis for everybody, only people with certain conditions. The recommended therapy then is also in table 16 in your handout. And the antibiotics are only to be dosed prior to the procedure, and generally ampicillin or amoxicillin, usually amoxicillin, and there's some alternatives for people who have allergies that you can use as well. So in this patient, he does need it because he has that history of endocarditis, so that's his condition that puts him at risk. And then a tooth extraction is a procedure that does require the antimicrobial prophylaxis. So the correct answer is B, because we only give 1 dose. You don't need to give any doses afterwards, so 1 dose prior to the extraction. Okay, I don't have a case for peritonitis or intra-abdominal infection. It's also included in the GI disorders chapter as well, at least primary peritonitis. I do have information though on secondary peritonitis in your handout that goes over the recommended therapy and how long to treat those particular patients. And there are very specific guidelines for intra-abdominal infections, and they divide it into either mild or moderate community-acquired infections or high-risk / healthcare-related intra-abdominal infections. So moving on then, I want to go to patient case number 11. This is RK. RK is a 72-year-old male who originally presented to the emergency department with redness and swelling of his upper right extremity. He had cellulitis. He was diagnosed with cellulitis. He was treated with clindamycin for 2 weeks. Now he's coming back with watery diarrhea 2 weeks after the antibiotic treatment. He has a past medical history of GERD, hypertension, hyperlipidemia, and osteoarthritis. Labs are done, and his stool is tested, and it's positive for C. diff toxin. He has an elevated white count up to 24.5, a lowered albumin, and an elevated creatinine of 1.74. Normally, he's around 0.9. So how should RK be managed for this C. diff infection? Metronidazole orally for 7 days, vancomycin orally for 10 days, fidaxomicin orally for 14 days, or rifaximin orally for 7 days. Okay. Getting, for the most part, some good responses there. So in your handout, I have some lists of risk factors and symptoms related to C. diff. Obviously, this patient is at risk because of his recent antibiotic therapy, specifically clindamycin, which is well known to be a risk factor for C. diff. He was also on a PPI, and as was mentioned in the previous hour, PPIs increase your risk for C. diff infections. Now, treatment-wise, treatment needs to be based on whether this is a mild to moderate infection or a severe infection. And in your handout, I have those definitions of what makes it more of a severe infection. And a severe infection would be those who have white counts greater than 15, which this patient does, or those who have elevated serum creatinines, put them into the severe infection risk, or those with severe abdominal pain puts them into the severe infection. So this patient is probably a severe infection. If it's mild to moderate, you can treat with metronidazole, either oral or IV, although oral is preferred. Only use IV if you can't use oral. And all of these treatments you can see are at least 10 days, 10 to 14 days. And then for severe, either vancomycin or fidaxomicin. Fidaxomicin is much more expensive than vancomycin, and there's no difference as far as efficacy, but there's less recurrences with fidaxomicin than vancomycin. But generally, people still recommend for severe C. diff to start with vancomycin. There's other things you can do for people who and commonly have second or third recurrences, and those are listed in your handout as well. So how should RK be managed? Well, rifaximin would be one of those for multiple recurrences if you use it at all. Fidaxomicin could be used first line. That's how it was studied. However, most people reserve that for recurrences. And because this is a more severe infection, you want to go with vancomycin over metronidazole. So the correct answer is B, vancomycin orally for 10 days. All right, and the last case is a case that has to do with surgical prophylaxis. Not really a patient case, but just a question that you get asked. So let me flip here. You're a pharmacist who closely works with the surgical department, and the surgeons provide you with principles of surgical prophylaxis that they believe are appropriate. So which of these is the best practice for optimizing surgical prophylaxis? You need to redose antibiotics for procedures longer than 4 hours or involving major blood loss. Give antibiotics for 24 hours after the procedure to optimize prophylaxis. Pre-op antibiotics can be given up to 4 hours before the incision. Or finally, vancomycin should be the antibiotic of choice due to its long half-life and activity against MRSA. All right. So there's a lot of information on surgical prophylaxis in your handout. This just tells you a little bit about the risk based on the procedure, whether it's clean contaminated, or dirty procedures. Obviously, as you get dirtier and dirtier, the incidence of infection goes up. This is a study that looked at timing, and this is an older study from the 1990s, but there's been a more recent study that has pretty much found that this applies as well, in that the lower incidence of infection is when you give antibiotics immediately before the incision, ideally within 1 hour of the incision, no more than within 2 hours of the incision. Waiting to give the antibiotics after the incision greatly increases your risk of infection, and giving too soon prior to the incision greatly increases your risk of infection. Also, the longer that the procedure lasts, the greater the risk. In those over 4 hours, you should redose antibiotics so you have adequate antibiotic concentrations throughout the procedure. Most of the time, the duration, you really only should give antibiotics prior to the procedure. There's nothing you have to give afterwards. Some people do give 1 or 2 doses afterwards, but there's no data that that's any better, and that gives you more optimal prophylaxis. And you basically only need activity against skin flora, except for in colorectal surgical procedures, and vancomycin should not be routinely used. And within your handout, I think I have doses as well, so the recommendation now is for higher doses of cefazolin or ceftriaxone, if that's what you're using. And you can see those doses in your handout. And so the correct answer here is A, redose the antibiotic for procedures longer than 4 hours or involving major blood loss. And at the very end of your handout, I have specific surgical procedures and what the recommended surgical prophylaxis is. All right, thank you very much. I'll be up here if you have any questions, and we'll start in 10 minutes with the last hour.